Thank you, sir, for the wonderful insight. I would once again like to thank GE, the founding partners of ETHealthworld. Now moving on to the next panel, Mohalla Clinic Issues, Challenges and Way Forward. Mohalla clinics being set up in Delhi have not just brought the primary health care to the neighborhoods, but they are also expected to lessen the patient load in multi-speciality hospitals, thus making their staffs, beds and hospital services available to more deserving patients. Now, the challenge is how to make this initiative model of healthcare more successful and if there is need and possibility of public-private partnership in this. For this session, we have Mr. Daljit Singh, President Fortis Healthcare Limited, Brigadier Dr. Arvind Lal, CMD, Dr. Lal PathLabs Private Limited, Dr. Sanjeev Bagai, Vice Chairman and Director, Manipal Hospital, and the moderator for the event is Mr. Arun Gupta, President, Delhi Medical Council. May I please invite the speakers onto the stage, please? Thank you.
The second one. He's monitoring us.
Very relevant points you said, sir. Absolutely.
Good evening, ladies and gentlemen. I'm Dr. Arun Gupta. I'm the President of Delhi Medical Council. And it's my privilege and honor to be among such an august gathering of who is who of the medical science in Delhi. And I would say right now something is very exciting is happening in Delhi. Right now, right here, this is the name of Mohalla Clinic. The concept of Mohalla Clinic came to our mind almost 3 years ago. I was associated with India Against Corruption and Arvind Kejriwal. And during our election campaign, I used to visit people, small cluster of people in the parks. And one thing I saw very commonly, that was common to all people, whether they're in clusters or they're in big cotis, the lack of accessibility of the primary health care. I always thought that this problem lies only with the slums and unauthorized colony, but when I used to take small meetings in parks with their old uncles who were sitting there, old age uncles, and they were sitting in the park and chatting around, that I used to ask, Uncle ji, आपने कभी blood sugar check करवाई है? बोला हाँ बेटा 1 साल पहले करवाई थी, कितनी आई थी जी? 300 आई थी, फिर क्या किया? पता नहीं, उसके बाद तो कभी चेक ही नहीं कराई। अब कौन जाए दूर दिखवाने? सुबह बेटा चलाता है फैक्ट्री में, टाइम मिलता नहीं। These are very common problems. And when you go to slums, there's a woman who's working daily, the small kids, she doesn't have time to go there. Now she cannot go to the private hospital because she cannot afford it. But once she has to go to government hospital, though they are said to be free, they're actually costlier than the private hospitals. So she has to go day one, she has to stand in the line for 2 hours, then she gets a chance to see the doctor prescribes some test. Next day she comes back for the tests, then she gets the test done. 3rd day she comes for the report, maybe 5th day she comes with report, 7th day everything's lost. Now she loses so many hours of work, so many days of work. It's really costlier than the private setup. So in that idea that came to our mind, that why not open small clinics in that area only. The revival of the old Mohalla clinics concept of Mohalla clinic, and the family physician being the nodal point of the whole health system. From there we started thinking how to do it. First we started, let us open 50 clinics, then 100 clinics. Then eventually we said, let us open 1,000 clinics in Delhi. And as a prototype of that clinic, first clinic we started 1.5 years back in a small area called Piragadi in Paschim Vihar, that is a resettlement colony. There we made a small clinic with 2 rooms, fabricated, this plywood and something, plastics. And this is a totally air-conditioned clinic, and just wanted to see the response of the people. Now we are amazed to see, now we are seeing almost 200 patients per day. A doctor sitting there, 9 to 4. She looks after all the kinds of patients. She prescribes all the medicines. All the medicines are available right there. All tests are being done there. Now this has been a tremendous success. After that second stage, we opened 100 clinics. Now these 100 clinics are all, none of them as permanent clinics, they are the old rented buildings. Idea behind opening 100 rented clinics so that we can understand what are the back-end problems. Back-end problems in terms of supplying the medicine, back-end problems in terms of how to do the test, how to take the samples, and how to supply the reports. In the back of that, we are we are working very hard. There's a lot of teams of volunteers as well experts who are working on that. And we plan to open all 1,000 clinics by the end of this year. And the civil work is on almost on all 1,000 clinics. So this is the background of what Mohalla Clinic is all about. And since such is a gigantic task, I know the government alone is not sufficient to do this thing. As per expertise is concerned, resources is concerned, we need the help of everybody all around us, private as well as government. So this platform gives all of us opportunity to share our thoughts, how to go about here. From here, I will share my thoughts, what we are doing, what are planning, and I would seek your advice also, what we can do to make it better and make it sustainable also. So let me start from Dr. Bagai. He's a well-known figure in the medical science, and he's known for his thoughts about how to medical science should progress. So sir, what are your thoughts and how can we help? You can help us on making this.
Hi, evening everyone. I think the concept is brilliant. I think primary healthcare is the need of the hour. But let me be, for 10 minutes, a cynic in this, so that we put checks and balances, so that whatever we do, we don't land up in a problem in which that it's neither sustainable nor it's scalable. Health is a state subject, and it shouldn't happen that the next government which comes and all the effort which you've done in, they don't take it forward. My first point is, let's not do anything to reinvent or redo something which already exists. So my question is, can we strengthen with this concept of Mohalla clinics the existing primary healthcare concepts? There's a very interesting report which is issued by NASSCOM, which was yesterday. I was at a conference in Bangalore, in which 47% of primary healthcare centers don't have the infrastructure ready. 53%, this is published data, 53% of primary healthcare centers don't have consumable, disposables and medications, and 36% don't have medical staff. Now, whenever we start something new, we put a lot of energy into it because we have a point to prove. I think we need to keep in mind that you are going to face a problem with regards manpower, with skilled manpower, with nursing staff, and with doctors. Now, if there is a concept of a sharing and integration of infrastructure and already a stretched resource in terms of manpower, stretched budget in terms of finances, I think it may serve a purpose slightly better. In the same context, I would like to add that almost every Arya Samaj and every Gurdwara in Delhi have healthcare units which run. Can this concept be merged with them? Because they have the staff, they have a lot of donations which come in, which is actually used in a very honest, charitable manner. Could the pre-existing facilities be merged with these Mohalla clinics? Rather than having these as standalone clinics, we don't have to prove a point to anyone. The point is we need primary healthcare, that's the need of the hour. Can we do something to merge these concepts which already exist? That's my first take. The second is, with regards the distribution of these clinics, we all know that, and what Mr. Arun just mentioned, we all know that almost 36% of the Indian population is pediatrics, is 0 to 18. And beyond the age of 18, about 28% is women. So almost for about 65% capture of the Indian population, there is practically very limited maternal and child care. Could some of these clinics be dedicated to women and children? I'm not talking just birthing, but women and children. And in the same context, I would like to mention something which has been published as what we call as Barker's hypothesis. So after World War I and World War II, there was a registered nurse in UK known as Mrs. Margaret, who went from county to county, village to gather data as to why children are dying so early. And she died in the process. And this data stumbled upon a person known as Mr. Barker, who's the epidemiologist, who published the data, so therefore the name is Barker's hypothesis. Poor maternal health increases 3 to 4 times the risk of early childhood death. So what we do yesterday impacts us today, what we're going to do today will impact us tomorrow. Can we strengthen from these primary clinics women and children care so that women get adequate care during the antenatal period and postnatal period? Can children get adequate vaccinations? Almost 50% of Indian women don't even could perhaps focus as some of them as specialized clinics for the largest segment of population. In the end, what I would like to say is I think the concept is brilliant. The devil lies in the detail. Implementation would be key. Sustainability would be the main success what you would be gauged at. Over to you.
Thank you, sir. There are certain issues you've raised. First of all, what will happen when the next government comes? Actually, we are working in a very phased manner, a very target-oriented manner. All 1,000 clinics will be opened right by the end of this year. And by the end of the next March, all our polyclinics, 150 polyclinics will be operational. So we are very ahead of time. We are not planning 5 or 10 years. Once the system is there, the system is working, I don't think it will be easy for any other government to dismantle the system. Now it works for this people, and people will stand for that. And as far as the lack of facilities, manpower, and budget is concerned, that has been the worst part of our healthcare system has always been. I have worked in PHC also, and I've seen how the primary center used to work. There was nothing. You're so right. Probably data are there, but actual figure much more than that. As far as manpower is concerned, we have opened up for the public-private partnership. Our clinics are non-manned by government employees. We are not hiring on pay scale. We have put up the tender in the market, and we have hired the people from the private sectors. Most of the people who are working in our Mohalla clinics are either women or retired people. What we do, we have given the slot of 4 hours, and we pay them per patient. Now it is their clinic. We have made a clinic, we have given a pharmacist, we have given the lab technician. Now it is their clinic. Now they have to see the patient. Now if they see the patient nicely, and they are very accountable, then the patient will come next day again. Now if the patient comes in next day again, they will get the money. Now depending on number of patients you see, you will get the money. So it's absolutely different concept. It's not the earlier concept in government when you used to come 2 hours late and go 2 hours early, and your attitude was so different. So it's all run by private doctors now, and they are being paid as per the number of patients they see. Now, as far as budget is concerned, budget is no constraint. Earlier, we all have a thought that government lacks money, but now we see that we have plenty of money, we have surplus money, we don't have any problem with money. The budget of earlier clinics which were made by the government was around 4 crore per clinic. Now we have made the same clinic with the cost of only 16 lakh rupees. Now once you make 15 clinics out of the budget of one clinic, the budget is no problem. I studied a clinic in my area, the earlier clinic. There was 14 people in staff. One security man, one just to enter the medicine, just to enter the register. The nodal point doctor was not important. There was so many staff. The running cost of that clinic was around 15 lakh per month. So budget is no problem because the money is used judiciously and the intent is right. You know what I mean by intent. Once the intent is right and you want to work, I think we have sufficient money. Within the same budget, we can provide the world-class facility, primary healthcare to Delhi. One good suggestion you give about integration of these religious places, Gurudwara and Arya Samaj Mandir, that we already did in our constituency 6 months back. 2 Gurudwara approached us because they were running this charitable clinic. They had a place, they have a doctor with them, but they were having some problems with medicine. So what we did, we said government of Delhi will supply medicines free. So now we are supplying the medicines free, but the problem is that once we started with 2 Gurudwaras, now all the Gurudwaras, all the Arya Samaj Mandir, they are asking it. So now next budget, we are providing a budget for that also. So all the religious places who are running charitable OPDs will be integrated with our Mohalla clinics. They will be given medicine free, and their all tests will be done by our Mohalla clinics. So we are integrating them also. And sir, finally you said about on the highlights of women and children issue that we are already aware of, and what we are doing that all the Mohalla clinics are integrated with Anganwadi workers also. The Anganwadi workers are the one who goes home to home and have a close contact with women and children. So these are the ladies who are looking after the preventive part of the medical care as well, iron tablets and deworming and even the social aspect of the problem, whether kids are going to school or not, whether they're getting vaccinated or not. So these kind of Mohalla clinics and Mohalla clinic doctor is becoming kind of a social leader now. Not on the medical problem, other social problems, he's taking the lead, he's giving his opinion. So that's how we are integrating everything in society.
Just to add one point, again in the data which is actually through NatHealth of last month, they have surveyed about 18 states. 60% of the ASHA workers and more than 50% of the Aroga workers don't have adequate training. So my point is, we have limited resources. My only take is, could we integrate the present pre-existing facilities to strengthen what you are doing, or what you are doing can strengthen the pre-existing facilities, rather than having two parallel governments which are running in healthcare. That's my only take. Whatever we start, it looks very nice. We will read about it, we will clap about it, it will come in print. What will happen after next year? I'm sorry I'm being cynical,
No, sir,
but we've been betrayed by the government after government for 67 years. You can make a mistake 1 year, second year, third year. We've been taken for a glorious ride, right?
So actually, sir,
how can you have just 50,000 beds in Delhi for a population which is bursting at its seams? How can you have government hospitals which have dogs in the ICUs and rats underneath the cribs of newborns? It's a point to ponder, right? How can you have doctors of such a limited resource, one person seeing 200 patients in a day? How can you have a sick person waiting in the ER for more than 6 hours and being told that, listen, I don't even have blood for you, neither do I have a bed for you? So in the pre-existing gamut, we can't wash away our population, and we can't grow doctors which take 15 years to cook. The point is, in the pre-existing gamut what we have, can we integrate, merge, synchronize our money, our resources, our manpower to have more success?
Actually, when we took over, there were almost 155 clinics, so there's dispensaries existing in Delhi. They were all huge buildings, very huge buildings, without any medical facilities, and people were not actually going there. Now what we are doing, we are converting those 150 clinics to the polyclinics. That was second tier. First tier, the Mohalla clinic, which was manned by general physician, once a week gynecologist, once a week pediatrician. Now once you have a problem which is not tackled by general physician, these patients will be referred to polyclinic. Now once you have 150 polyclinics in Delhi, that means 2 polyclinics per constituency. And these polyclinics will have all the specialists along with ultrasound and X-ray machine. So that will be the second tier. So we are actually utilizing the existing medical system as well. And one thing you said about the problems of availability of bed in hospitals. So we have devised a very ambitious plan. In last 70 odd years, we have only 10,000 beds in government sector in Delhi. By the end of 2017, they will be doubled to 20,000. We are already working on that, very seriously working on that. Designs are being planned, and by the end of this year, work will start. And by the end of the next year, capacity of inside bed in Delhi will be doubled. And by the end of 5 years, there will be 40,000. That we are working, very sincerely working on that. And one of the major aspects of Mohalla clinic is availability of laboratory tests inside. Now in the first Mohalla clinic which we opened, we put a small analyzer where we do 50 basic tests, and the report is available right now. But when we are opening hundreds and thousands of clinics, our idea is to have a blood collection or sample collection center right there. And we are planning to open some regional laboratories where the sample will be sent and the reports will be delivered back to the Mohalla clinic. Now we are working on that also. Dr. Lal is sitting with us, and nobody is more than him how to run a chain of pathological laboratories. He is doing this successfully. Sir, I would like to have your opinion, because 1,000 Mohalla clinics is going to be a mammoth task for us. What is your suggestion how to make it streamlined so that we can learn from you how to go about from here?
Thank you, Dr. Gupta. The first thing which I would like to reiterate is that now medicine has changed over the years, the last 40 years. When we were sitting just before the session started, so we were talking amongst ourselves that now there are so many doctors, so many private hospitals, so many government hospitals. And there was a time when we could just go to the locality doctor and he would examine us and give us some, kind of a mixture or some medicine. And that was the end of the story. And we have all grown up quite well. We all look quite healthy, I think over too healthy. But that was the, what was happening. So what has happened over the years, there has been a very subtle but a very perceptible, shift towards evidence-based medicine. Second thing is that pathology tests are now responsible for over 70% of all medical decisions. So there is a cause and effect kind of a theory. And these days when you have, sore throat, you are not supposed to go to a chemist and say कि मेरा गला खराब है, मुझे आप कोई antibiotic दे दीजिए. वो आपको 2-3 दिन की कोई antibiotic देता है, and that is still happening. So one of the barriers I'm saying to good medicine is that you have to put a stop to this, kind of, free prescription or no prescription or over prescription. Anybody, anywhere can write an antibiotic, etc., and that is the end of the story. So now it is evidence-based medicine. If you are having a sore throat, you are supposed to go to a Mohalla clinic, a Mohalla laboratory, get your throat swab done. Maybe you get, can grow streptococcus there, and you can have something which is not, of a fourth or third generation antibiotic, but something like erythromycin can be used. So these are basic concepts of which all doctors present here have, they all know about it. But I think it is now time to, pull the rabbit out of the bag and say that, well, we are going to practice, real medicine as we have been taught. So that is where I would like the government to take the first lead. That it should not be some kind of a thing is happening. I know there are quacks. If you talk to the doctors, well, we don't want quacks to be there at all. But as we are reasonable human beings, we understand that there are Unani system of medicine, there is Ayurvedic system of medicine, there is homeopathy. We've got nothing to, say against those people. But everybody trying to, pick up on an antibiotic, who gets the patient first, and the patient will not come tomorrow if the fever doesn't go down. This is absolute nonsense. So now what we have to do is to inculcate this kind of, go to the second tier of, giving medical, care. And that is to make sure that your people, at least from our point of view, that is the lab point of view, they are, following certain kind of, minimum standards. Now we brought, quality into India. We were the first NABL lab. We were the first College of American Pathologists lab to be accredited, etc. And what did we do? We opened our fist. You see, you cannot shake hand with a closed fist. So, sir, what I am saying is that now time has come, perhaps, that the government also took a step forward and said, okay, let us see and ask critically how we can improve the standard. After all, what is ailing the Indian health industry? It is accessibility, it is affordability, and it is quality. So I'm talking about accessibility. You have created affordability. There's no question. I think it's all free. So let's talk only about quality. Because if you do not bother about quality, I know quality costs, but bad quality will cost you even more. And it is very, very easy in Delhi, to something to go around, on channels on TV and breaking news, etc., etc. Somebody went there and this is what happened. We all live under this. In our pathology setup all over India, we are testing over 50,000 patients a day. But how have we been able to manage it? It is by, having a laser focus on quality. So, Dr. Gupta, what I would like to suggest is that, you show us, you call people like us. I'm not saying don't, people who have got their labs accredited, and we are having more than 30 labs now, which are accredited all over India. So we can tell you, and there is going to be a, constant quality improvement program, QIP. Now you are off the first base. You have created the Mohalla clinic, you put the doctor there, you put the lab technician there, etc., etc. For heaven's sake, don't let him get away with murder. That whatever he, puts into an analyzer, whatever report comes out, he gives it. So who is going to check on that guy? Because in my profession, this is very, very important. In fact, we have reached a stage where we do not make, by and large, any mistakes while testing. All the mistakes are done at the pre-analytical stage. That I take somebody's blood and I put the wrong label, a wrong barcode on it. One this is about 30 years ago, and I'm, very, glad to share it with you. One patient of mine came in the evening, Sardarji, with his wife. He said, Dr. Lal, I must congratulate you that now I've got no diabetes. I said, very good, you must be looking after yourself. He said, but my wife has got it now. So, so what had happened was, in the morning when we were taking the blood, Sardarji's label was put on his wife's label, etc., etc. So that is, where the quality starts. So these are a whole list of, pre-analytical errors. I can go on and on. But I think it would be suffice to say here that as far as possible, do not give the ability to start testing there. Every doctor, every pathologist, every minister would like to have testing right there and then. It doesn't matter if you ask me, because we have perfected the art of transporting the samples from A to B to the main testing lab, maintaining the temperature between 2 degrees to 8 degrees. Even when the outside temperature is 45 degrees, we can maintain that temperature for 2 days. We get samples every day from Agartala, from Ladakh, Leh, Kanyakumari, etc. So it is possible, and you can have better quality if it is done, in a central. I'm not saying that all will be, you'll have to have only central laboratories, but you can have this, what we call, a hub and spoke model. So the outermost is, your primary health center or a primary Mohalla clinic. They're allowed to only collect blood. And the number of tests have increased, as you know. He has to tell the right information to the patient that, okay, your blood has been taken, your report will be available at 7 p.m. today. There should not be a test which takes another 2 days, because the man will come and he is in agony. He's got to go and see the doctor at 8 o'clock, and the report is awaited only after 48 hours. So small things like this, we would be very, very happy to help you, sir.
Yes, sir. Thank you very much. And as far as our view is concerned, we are trying to open regional laboratories across Delhi, and Mohalla clinics will be only sample collecting centers.
Correct.
And we plan to accredit all the laboratories by NABL. That is our plan. And because the task is very mammoth, almost if it's on average 100 clinics, 100 patients per clinic, there are 1,000 clinics. That is 1 lakh patients per day. Now, if you calculate 1 test per patient, that is 1 lakh patient, 1 lakh tests per day.
Correct.
It's a huge task. So you are so right, sir, and I will be in touch with you, and I'll definitely will have meeting together so that you can suggest, sir, what else we can do about laboratories. And now we Dr. Daljit Singh is with us. Dr. Daljit Singh is the president of the Fortis group of hospitals. Sir, you are probably running the biggest chain of tertiary level hospitals in Delhi, all over across India as well. Now, primary sector we are doing, secondary sector government is doing also. Tertiary level we are not actually planning to go, because tertiary level is a bit costly for government. What we are planning to outsource to the big hospitals like you. Now, where do you see your role as a big hospital in the primary sector as well as the tertiary level as a complement to the government, what we are doing here?
Well, okay, thank you. First of all, it's an honor to be called a doctor. I'm not a doctor, but I'm the company of great guys out here on the stage. I think your question is pretty valid. I think let me just get back to the principle that has been spoken about, and my colleagues here have put across some very relevant points. The important aspect of a public-private partnership, I think let's understand the fundamental principles. It is about a partnership between the government, it's partnership with a private player, where the purpose is to harness the capability of the private sector to deliver efficiency, to deliver quality, to deliver speed at the most economical prices, whilst maintaining all these parameters that Dr. Lal and Dr. Bagai mentioned, especially around quality and sustainability. It's a very important consideration. The private sector has nobody to fall back on. So if Dr. Lal's laboratories don't work, I mean, there's nobody to bail him out. Or if my hospitals don't run, we have nobody to bail us out. So there is a compelling need for us to continuously look at the way that we operate, both from a patient care point of view, quality point of view, as well as from a price point of view, in a manner that is totally sustainable. sustainability is absolutely key, and sustainability will not happen if the other pillars are not okay. So I cannot run an operation which doesn't subscribe to quality or which doesn't have good clinical outcomes, et cetera, et cetera. That's absolutely paramount. I think from the government's point of view, harnessing private sector capability is perhaps the easiest thing they can do. Unfortunately, for too long, especially in the healthcare sector, we've never had a situation where there's been a good partnership between the public sector and the private sector. There's always been a huge amount of mistrust, and even today, when we see news channels or newspapers, it's always a we and they. So private sector is out there to simply profiteer, and yeah, you got somebody coming in?
Yeah, we have been joined by our fifth speaker for the panel, Dr. Prabhakaran Dorairaj, Vice President, Research and Policy, PHFI.
Good, welcome, sir.
Yes, sir.
How are you? No problem, that's fine. So I think it's important to recognize what each party actually brings to the table. That's going to be a very important consideration. And private sector capability comes in the field of innovation, in terms of standardization, in terms of quality, and in terms of capital that they bring to the table. Government doesn't necessarily need to spend everything in terms of whether it's putting up infrastructure or putting in laboratories. I mean, if there's capability available, if Dr. Lal has a laboratory, if SRL has got laboratories, there are big laboratory systems, easiest thing is to have partnerships with such partners whom you've accredited. You've assured yourself that their standards are good, they're ethical, they're able to provide you services on an OPEX model, operating expenditure model. Why would anybody want to invest money there? So today when we run hospitals, we try and look for partners, real estate people who got land, who have the ability to put up a hospital. We say, why don't you set up the hospital? At least you'll save us the need to block up capital. And we bring in our people and we bring in our technology and we'll run the hospital. I feel that the government's approach towards the PPP should be driven by that consideration. And I think you mentioned the point that today you've not, these 100 Mohalla clinics that you've got are all hired out facilities. My submission to you is don't construct your own facilities at all. Why would you spend crores of rupees spending on a building which is absolutely dead, which can do nothing for you? Keep that money for running your operations. You should become the payer for services. You should become the biggest buyer of services. You should demand quality, and you should exercise regulation. Demand quality, demand outcomes from whoever your private partners are. I think that way you hold the high ground. You will have people coming into you, presenting the credentials with quality standards, accredited, etc., and you will get exactly what you want. So I feel that that's a very, very important consideration. I think if you look at, you asked me a question as to how can large hospital systems, partner with you. One very clearly is in all aspects of delivery, I think it's possible to partner. Whether it's going to be large hospitals or smaller hospitals is a separate point. But the fact is, right from whether it's doctors, whether it's nurses, whether it's provide you an IT system to give you quality control reports, to provide you centralized laboratories for testing, to subject these laboratories to quality scrutiny, all that can be provided. I think if you take it a step further, there are many other domains which are susceptible to PPPs. And I think some of them are being tried out in a somewhat lethargic manner. It could be dialysis, it could be ophthalmology, it could be dentistry, you name it. You can have implants inside your hospitals, inside government hospitals. For example, we've got Dr. Mahajan who runs a fantastic chain of radiology centers. Now, those implants can be given to professionals. That okay, we don't want to invest in a 12 crore MRI. It's your job to provide MRI services, CT scan services, and Dr. Mahajan, but you are also required to stick to all the regulatory norms, get all the permissions, and please run it for us. Now, he's going to make damn sure that he runs a very, very tight operation. We use he's one of our partners that we use in some of our hospitals. Now, I think the government should look at it from that point of view. At the end of the day, Your role is to drive a social agenda, and you should be looking at harnessing private sector capability to your advantage. And when you bring 4 players to the table to negotiate with you, you're bound to get very competitive rates. Quality will be assured to you, and you'll have very, very happy at the end of the day. I think your Mohalla clinic model, whatever I know about it, and I know a fair bit, I had a chance to be with your minister a few weeks back, I'm personally very impressed. Provided we are able to create deep roots in the system to ensure a sustainable and a quality operation, the points both my colleagues have very forcefully emphasized.
Thank you, Dr. Daljit.
Arun, can I just add one point which my friend has added? I think the full concept of a PPP is so flawed. I think the first thing which probably government agency would try to do is what is their margin in a partnership. I think if you're dealing with private partners, you should be giving a functional collaboration rather than asking for a financial collaboration. These facilities exist in Delhi. My only request is don't reduplicate things which are already there. If you rationalize pre-existing facilities, your results will be magnified and much better. And the second thing is you'll see a lot of PPP models languishing. There's a large hospital in Tamirpur, which is a 750-bedded hospital. The stipulations and regulations which the government wants are so absurd. I'm sorry for using this word, they are absurd. There is no crime if a private person wants to make money. I want to make money. I'm saying openly. I'll make it ethically. If a lawyer makes money, people will say, wow, he's really successful. A doctor makes money, he'll say, why is he making money? The full concept has to change. I think the private people are making a 75% share of the market is held by private players. And there is no shame and there's no sin in a private person who's making hundreds of crores of investment in making profit. But these facilities exist. My request to you with folded hands is use first the pre-existing facilities. Rationalize the resources, rationalize manpower, your success will be sustained. If you try to rebuild a model which is already there and it's running pretty robust in private, without private Delhi healthcare would collapse, right? You would find it a lot more difficult.
So for us, sir, actually the basic concept what you said is that not we and they, it's for us. Now I am a doctor in the private practice. I'm working for 25 years. So I know the role of private sector in the management of healthcare of Delhi. This cannot be done without the help of the private sector. That is the fact. Now, we accept that fact and we honor that fact. For us, the private sector is not kind of money makers and looters, all that. We accept their role in the society and we acknowledge that and we try to help from them. Now, as far as utilizing the resources is concerned, the basic clinics at the doorstep level was not available. So we are creating them. The already existing big clinics we are converting into polyclinics. Now Delhi government has 39 hospitals which are at the best you can say secondary level hospitals. As for tertiary level is concerned, the private sector is doing extremely well. So we are not actually going tertiary level care. Tertiary level care we want to collaborate with the private sectors. Now how to do about that? Like about 1 month back I had a meeting where I called the big, all the people from the big hospitals from Fortis, Max, Gangaram, they all came, all 12 people came and Satyendra Jain was sitting there. And we had a talk with them, how they can help us. There were certain ideas they gave us. They said they were running around 60 to 70% capabilities, ranging from 50 to 80. Now they had 30 to 40% beds available. Now these people are willing to give us those beds at some rates which is acceptable both and affordable to us. So 30 to 40% beds, this is a huge amount of beds which are lying back in the private sectors. So they are collaborating with us and they are giving our rates and we will be using those beds as well. And for the laboratories are concerned about CT and MRI is concerned, because you people are doing very well, Dr. Mahajan is doing very well this thing. So still you have some off-peak hours times. So we are asking for them some tendering of off-peak hours so that we can send our patients there. So those can be MRI and CT scan can be done at reasonable rate, which can be affordable to us and can be affordable to you. We want you to take money, but okay, lesser amount and off-peak hours. And third sector where private sector is really helping us in training also. Because training part of the government is absolutely zero. So recently 35 of our doctors went to IIM Ahmedabad. some training in management also. So I had a talk with some ex-people also. They're also helping in training of nurses and administrators also. And in all government hospitals, we are creating a team of young MBAs who are looking after the administrative part also. So in these sectors, private sector is absolutely helping us. And some certain hospitals, outright, we are outsourcing to the private hospitals where they can run them. So that's how we are taking the help, and still we are open to ideas. And if you have some other ideas where you can help us, government is absolutely open to take those ideas.
And Dr. Gupta, I just have one more point. When running any collaboration with the private sector, I think one of the issues that have been universally felt by all of us is the inordinate delay in payments. I mean, they are totally unpredictable. And I think that's something which you must consider. You know, I raised it with the minister last time, and he was very positive, very progressive in his thinking.
Basically.
But really, that is at the heart of the matter. If you don't get paid for 1 year, when you're offering rates which are 25-30% lower, I mean, it doesn't work for anybody, frankly. So I'll just leave that with you.
So this fact actually is true for not only the medical, in all the sectors of government. When you have to make the payment, they delay it for years and together. That escalates the cost. And at times, the reason of delaying is the bribery also. People delay it because they have to get the bribery. Now, sorry.
Arun, the fact is it's not delayed payments. They're absurd payments. A cobbler will take more than 60 rupees. Why should a medical professional be subjected to seeing any government agency patient for 60 rupees? I think it's humiliation.
Yes, absolutely. I agree with you.
I would rather see the patient completely free. Because I know that 60 rupees is not to come. And if the hospital is going to try to recover 60 rupees, it's going to spend 40 rupees trying to recover that 60 after 10 years, in case the file is obtained or found. So I think we need to be rational. You need to treat the medical professional adequately well. You need to pay the medical professional his normal charges. I can understand if a normal consultant in South Delhi is taking a really top-end super specialist is taking 1,000 or 1,200 or 1,400, don't give him that, but at least pay him 500, pay him 600, pay him 700. You're paying him 60 rupees. I'm sorry, I stand corrected, 61. That's the joke.
CGHS?
Yeah, I'm just saying
Yeah,
it's just a
CGHS,
joke.
yeah, those are the
It's
rates.
just a joke.
Yeah.
If I go to an Air India counter, would I get a ticket at 61?
Anyway, I think I can suggest something, also in the same vein of, trying to work with the government. This private-public partnership has been always been talked about, but, the walking the last mile and getting it done is actually the real problem. So what we are offering from our side, Dr. Gupta, is that we have an organization which is now known as Nat Health. And Nat Health is the national body of all medical professionals, just like NASCOM. And I have the pleasure of, introducing you to Mr. Anjan Bose, who is the Secretary General, sitting right here. I am the Senior Vice President. Daljit is a member of the Management Committee of the Senior Committee. So what we are doing is that we have put our thoughts into a document for a public-private partnership. And it is, again, when things have to happen, Daljit is in charge of that.
Okay.
So kindly make use of Mr. Daljit Singh's, expertise. We are putting in something. You please study it, because everywhere we go, when we go to the center, they say, well, health is a state subject. So now we are the state. And it would give us real joy, that Delhi is our city and something fantastic can be done here. You've got world's best airport here. You've got one of world's best metros here. So why not world's best, health facilities here? So in a positive way. And the second thing which I just wanted to draw your attention to is that, now people are going to die of, what we call non-communicable diseases or lifestyle diseases. 60% of our deaths are going to happen from there. And nobody is immune, whether you are a young man or a rich man or a poor man. And I'm talking about the urban poor. And here, these are led by, diabetes, high blood pressure, cardiac disease, cancer, and many others. But I am sure that nobody here, can say that they don't have at least one patient in their family who's suffering from one of these diseases. So out here, again, people who have done really human service here is sitting next right to us, Dr. Prabhakaran from PHFI, and we must, get this answer from him, that how can we control these deaths from lifestyle diseases? That's all.
Dr. Prabhakaran, your input. How can you help in Mohalla clinic?
First of all, my
Major
apologies, because
problem.
in my calendar, it was at 6 p.m. and I reached exactly at 6. I don't know how the confusion occurred. I'm going to change track a little bit. I'm not going to get into the debate of PPP. PPP, as in common parlance, obviously is public-private partnership. But I think we are here for partnership for public purpose, and that should be our PPP. So the question is about NCDs, which constitute almost 2/3 of the problem, and how do we tackle this problem? To tackle this problem, I think we should get away from specialists. I'm a cardiologist, but I'm saying because there are only around 3,000 cardiologists in this country. There are around 1,000 endocrinologists. There are around 50,000 to 100,000 internists. A large majority of the care is provided by primary care physicians. And apart from primary care physicians, you would be very surprised in most parts of India, care is provided by non-allopathic registered medical practitioners. They may be trained, untrained, they may be Ayush, whatever. Now the question is, let's tackle the primary care physicians, and they don't have the capacity, or they are diffident to treat NCDs, and we need training programs, and that's one of the things which Public Health Foundation of India has embarked on in terms of training primary care physicians in the management of diabetes, hypertension, chronic obstructive lung diseases. So the idea here is that they're the first level of contact. They treat common conditions where it can be treated commonly, and then establish a robust referral linkage. And the referral linkages has to be in both directions, the direction from the primary care physician to the secondary and tertiary care physician and backwards. The second thing I was told is to discuss the issue of Mohalla clinic in the context of non-communicable diseases, and I think Mohalla clinics have a very big role, because nurses and non-physician healthcare providers are a big key to the management of non-communicable disease. In fact, in developed countries like Canada and UK and Scandinavia and United States and other places, it's the nurses have been given permission to manage. And nurses are very useful in that sense because of the lack of availability of doctors, and therefore we need to provide them a certain set of, empower them in providing certain set of guidance in the management of hypertension and diabetes. Lifestyle advice, for example. How many doctors really provide lifestyle advice to patients? They hardly spend 2 or 3 minutes. A busy cardiologist at All India Institute, I used to spend 2-3 minutes, and I used to say, namak kam kar lena, ye kam kar lena, but who is going to give proper advice? So therefore, they are extremely useful, and especially if you empower them with an electronic decision support system loaded on a mobile phone or a tablet, which we have demonstrated to work in multiple parts of the country, they are useful. The second thing that we need is simple point of care devices so that patients don't run around. They have access to care, and these point of care devices can help. I mean, most people would require a lipid profile like glucose, urea, creatinine, hemoglobin. So can we load that and get a simple point of care device done? And there are experiments around that. We had the Fortis slate which is being evaluated. There's an INA device in Bangalore which has been done, which is excellent, which gives you multiple tests with less than 100 rupees. And there are others. The third is, blood pressure measurement. Blood pressure measurement can be done by nurses, and the data could be given to the doctor. So they just need to feed in the data into a tablet. It would give a printout. They can go to the doctors. The third is the concept of a virtual clinic. The nurse is there in the clinic. Like, for example, patient has to contact for, let's say, patient is taking anticoagulants, has to get an INR done. The patient will have to go to a lab. Not in Delhi, it's easy, but if you're outside Delhi, they have to go to some lab away. Then they get the report 1 or 2 hours, 2 days later. So now the question is whether we can have point of care devices, train them. The point of care device is hooked by either Bluetooth, internet, whatever, and the nurse gets the data and just calls up the patient and says, okay, you change. And in terms of long-term secondary prevention for heart failure, for example, you could have simple 3 or 4 questions which people call a phone or put it into an internet. The nurse looks at it and says, oh, this patient's weight is going up, this patient's BNP is going up, or this patient has severe symptoms, and this is the time to get the patient in. So we are getting the patient just before they get into that vicious cycle of complications. So there are huge potentials for Mohalla clinic. We have made a start, and I think innovations are required which can actually strengthen these Mohalla clinics. I think it's a great concept. Only thing is it requires additional innovations. And I think all of us are partners here, and this is a partnership for public purpose and not necessarily, we shouldn't call it a public-private partnership.
Dr. Gupta, I'd just like to add on to some wonderful points he's made. I think that you have a great opportunity through the distributed framework that you're developing to collect data that currently no other state has got. For the state of Delhi, you should be able to develop a health heat map. I mean, how many people are diabetic? How many have got high BP? How many have got what other types of problems? I mean, you should be actually able to do all the basic diagnostics and come up with some very interesting statistics and observations that can help us to focus medical resources really where they are required, to prevent the sort of eruption of serious NCDs, which are inevitable if you don't control them now.
Sir, I just want to say, I think the data are there. I don't think we should get any more data because right now we know that Delhi's prevalence of hypertension, it's around 40%. The prevalence of diabetes amongst adults above the age of 20 years is around 20 to 25%. The presence of pre-diabetes is very high, it's around 32%. These are the people who convert to diabetes within the next 5 years, a large majority of them would convert. We know the prevalence of dyslipidemia. I think as Juan Goethe said, knowing is not enough. We should be willing. Willing is not enough, we should act. And the time is to act. I think gathering data should go in concurrence with the interventions, and I think we should start intervening, and Mohalla Clinic is a good way of starting the interventions.
Actually, I agree with both of you gentlemen, but as Dr. Daljit Singh, the data part is very important in quantifying the disease and understanding the problem of the disease. Now, what we are doing in Mohalla Clinic, we are using tablets, we are using full technology use. Now, every patient which enters the Mohalla Clinic, his whole data are being entered in tablets. Now, every patient has, now we have data of every patient with us. Now, these automatically generates data of the whole Delhi. So, that would understand, make things easier to understand the quantum of the problem. Once you understand the quantum problem, it will be easier to plan. Now, as you say, how to intervene. Now, what we are doing, our Mohalla Clinic doctors are being groomed as a community leaders as well. They're not just doctors, they're leading community leaders. They sit every day there, 4 hours every day. They communicate with people on a regular basis, not only medical problems, all other problems as well. So once you are kind of friend to them, you are kind of family physician to them, now comes the role of your advices and especially the preventive advices. So once like what kind of practice we do in our clinics, we spend very short time with patient, and which is most of the curative practice. But once you develop a leadership, the leadership is like everything. It's not about medical problems, it's social problems as well. So there comes the role of Mohalla doctor for the prevention as well. Now, as far as training is concerned, we are also focusing on that. All our doctors are being trained in all the diseases. We are making our protocols as well. We are all our systems of training them, in-house training them, and certainly with all guys you around, and you all have expertise in that. I will take your advice as well and your expertise as well. So the training part will be taken care of.
Arun, can I add something on the data? Data is an ongoing process, right? In fact, any amount of data need not be adequate. Okay. What is of concern to me is data analytics. Yeah. We gather the data and then actually it gathers dust in government Godreges, right? Data can give us a lot of information.
Yes.
And here comes technology as far as digital technology is concerned. Why we get scared of data is because we don't know what to do with it. And it's all manually entered. If this can be digitalized and it's easy, you have good, excellent local, national and international partners who can do this to you at a price, which is useful for us, then we can actually interpret the data. Worldwide, why is the epidemiological studies better than ours? Because they know what to do with the data. Yes. Point number 2 is they have predictive scores. So you can actually, within Delhi, yes, sense out and warn the public at large as to which year you're going to get a more deadly strain of dengue. Or, for example, of any other communicable or non-communicable disease. That is lacking. And here comes an opportunity in which you have perhaps the largest database. Yes, sir. You just must know what to do with it.
Quite right.
And that's available. So there are 2 messages. One is data analytics. 2 is predictive scoring, individual scoring for individual diseases, not only lifestyle diseases, but other diseases. That is a preventive part of your overall game.
So I'm sorry if I came across as saying that we require data. Data has to be obtained concurrently. So, I think we require a robust HMIS system, yes, and in that sense you're doing very well. Sure. And I think there are lots of organizations within India to do very good data analytics, and we will also be very happy to help in data analytics.
In fact, again, taking on from what Dr. Lal mentioned, NatHealth has a collaboration with NASSCOM in this domain. That means how do we get IT and the healthcare sector to actually work together to provide us this level of expertise.
So with the use of IT, actually, I think the data gathering is getting much easier because all our doctors are equipped with the tablets. Now every data is already going on our server. So automatically we are generating all those data. Plus all the, as per government is concerned, they are going to provide health card to all the patients in Delhi. Now whenever you enter a hospital, you have to just swipe your card, all your data will be on the server. So automatically data will be covered, and you're so right, sir, unless what is the use of data, unless you interpret it and make your policies according to data.
You know, one of the challenges which you can actually address is, for example, you know, diabetes is rampant in India, and I don't know, Dr. Prabhakaran, what's the statistics for Delhi, but I suppose it would be about 8 to 10%.
No, Delhi is for anybody above the age of 20 years, if you take the Delhi population, it's 22%.
22%. So here is the challenge. Now, can the Delhi government say that all these uncontrolled diabetics, can we say that within a reasonable period of time, say 1 year, we can bring down their hemoglobin A1C by, say, 2%? Because we talk about smart cities. Why not make Delhi a smart health city? And I'm sure we can do it. Second point I wanted to make was that there is now a very, aged or elderly population coming in. In 1947, the average age of a man in India was 47 years, and the lady was 49 years. This has fortunately shot up to 67 and 69 right now. But now in Delhi, with better medical facilities, both in the private and the other sector, government sector, we have a large number of people. You just mentioned that you go in the morning parks, there are elderly people, 75, 80, they are going. So let us do something for them also, the geriatric age group. And here again, we have Dr. Om Sharma. So can you just stand for a minute so that everybody can see you? He's done a yeoman service for geriatrics in Delhi. So please make use of people like, Dr. Om Sharma. Because whether we like it or not, there are friends of mine staying in America, and they say that, can you suggest somebody who can look after my aged parents? Because they require not 24 hours, but they require some specialized skill in managing them.
Very true.
This is very well taken.
Yeah, very true.
I think after such elaborate discussion, and anybody has some question from audience, we are willing to. Any queries or any suggestion about Mohalla Clinic? Yes, sir.
Services after 4 o'clock. Thirdly, why don't we make all these private practitioners in that area compulsory to work in Mohalla clinics for say about 4 hours a week? There were so many 8 or 10 practitioners will be there. They can always work in that clinic. You can pay them. And the last is, I like to know how, as you said that you will pay some amount per patient. I like to know what amount do you pay. I hope it is not laughable amount.
Actually, I will take the last question first. It is actually, I'm myself as a doctor, so I know it cannot be laughable. I cannot divulge the exact amount, but their average they are getting more than 70,000-80,000 per month for 4-hour slot. Is it good enough, sir?
Yeah.
Especially the kind of doctors who are sitting at home, retired doctors. Yes, sir. And but it will be much more than that is the minimum, much more. Some are getting more than 1 lakh check now already.
That's fair.
So just for 4 hours, I think it's a good enough for a lady sitting at home.
That's pretty
so that is a reasonable, I think,
yeah,
for us,
sure,
right?
Sure, yeah.
And about time slot, you have said about evening clinics, we have already in that mind. So it is a beginning. We are seeing how many patients we get. Depending on the requirement, we will plan the evening OPDs as well. And as far as hiring the doctors from and making them compulsory to sit, I don't think it's a good idea to make it compulsory because already we have sufficient doctors. We don't have enough doctors, so they are willing to work. So why to force somebody if we are willing persons? And that's all.
Schools, they say. Schools, etc. You want to.
Sir, like I told you, we have only one clinic which is permanent now, and other 100 clinics are temporary buildings just to see our back end problems, how to supply the medicines, how to supply the, how to do the test. So we are not disturbing the schools. Schools are the differential. These 100 clinics are temporary. Within the by the end of this year, we will all 1,000 clinics running well. We don't have a problem with the spaces now, so we don't have to enter the schools. Sir.
Unfortunately, we can't take any more questions as we have been joined by Mr. Satyendra Jain, Minister of Health of Delhi Government. Thank you very much, gentlemen.
Thank you.
Thank you.
Okay, thank you.
Thank you very much.